I'd now like to move on to introduce Jane Townsend, who is the Chief Executive of the UK Home Care Association. And I know that Jane is an extremely passionate advocate both for care at home services, but also social care more generally. And the title of her talk today is a very good one, which is there a different way of doing things? So, Jane, is there?
Thank you very much, David. And Alison asked me to talk about whether there's a different way of doing things. And in many ways, one has to wonder why even ask that question, because for years now, there have been conferences and learned papers talking about the opportunities for embracing technology in people's own homes and supporting them at home. We've got smart homes with environmental controls, just regular television and smartphones and tablets for communication, Internet of Things, sensors, wearables, remote monitoring that Tim's just been talking about, of all kinds of health issues can be tracked from your sofa, and even robotics and how far that could go in terms of making up for the shortfall of care workers. And we've got artificial intelligence, neural networks, fuzzy logic, machine learning, and all contributing to the big data that Caroline talked about that is so important. And when we have that data, in principle, the goal is to be able to personalise care and improve outcomes for people, to drive quality, safety and efficiency of care, also to enable predictive and preventative health strategies, to identify trends, to generate data that helps in research and policy making. As we've all discovered during COVID, we've been a bit short on data when we've needed it. And ultimately, the hope is that we could also save money. And that's not from that's by improving outcomes and reducing healthcare utilisation. But despite all of these promises, we are still in practice often left with a dominant model in domiciliary care of our committed and compassionate care workers visiting people in their own homes in a quite resource-intensive way, without much support in many cases from other professionals. And many care workers have felt particularly lonely during COVID when other professionals have been working more remotely. They're often electronically tagged, paid by the minute for short visits, giving of their own time. I mean, the stories that I've heard during COVID of how the care workers have really done so much voluntary work on top of their long hours is just so humbling. And many of them too still keeping records on paper. So, I ask myself, why is there such a big chasm between rhetoric and reality? And will we have to wait until pigs can fly before we get a change in the way that we want? Well, you don't have to be Sherlock Holmes to figure out that state-of-the-art approaches to improving outcomes using clever technologies like artificial intelligence and so on, which are here and available and work, just can't happen if we're paid by the minute for completion of tasks. So that the incentives are just not there, the mechanisms are just not there to be able to capitalise. And on top of that, we have our budgets in silos. The bulk of government funding is poured into the NHS. The amount spent on home care is only 4% of the budget spent on the NHS, probably even less now because another 7 billion has been directed to the NHS. And it's actually quite difficult to make a business case for investment in technology and innovation in home care when quite often the benefits will occur elsewhere in the system, for example, in reducing healthcare utilisation. And even within the NHS, often the majority of the funding is directed at acute hospitals rather than at community services. And there have been numerous reports and advice to try and tip the balance in favour of community care, but nothing much ever seems to happen. And this is despite the fact that the majority of people are at home. At any one time, there's only about 0.1 million people in hospital beds, about 0.4 million people in care home beds, and the rest, which if you add together Carers UK estimates of the 13.5 million people being cared for by informal carers, and then maybe just under 1 million people being cared for formally in their own homes, 15 million people in their own homes needing support and care in some form versus only 500,000 people in institutional forms of care. But the entire debate and focus is on the institutional forms of care. And of course, the emphasis on the NHS and care homes has often left councils with insufficient funds to purchase home care at fair and sustainable rates. So, as the National Audit Office report today has highlighted again, fee rates for care and home care in particular are often inadequate, leading to an unstable provider market and less capacity than we need. It also means that pay terms and conditions of care workers are poor, making it an unattractive proposition. So what's the answer? What do we need to do differently? Obviously, we need to start with people and their needs. And all of us want to flourish within our communities. 9 out of 10 people say they want to stay at home. And it's very encouraging to hear Tim speak about the need and the desire and the actions being taken to measure and monitor healthy lifespan and other related metrics at integrated care system level. And that's really where we need to move towards. And, you know, there are numerous health indicators and wellbeing indicators, the experience of people, citizens using services, and cost effectiveness. So if we invest in home care enabled with technology, can we demonstrate a reduction in healthcare utilisation, a reduction in people going to GPs unnecessarily, a reduction in people being admitted to hospital for things that they shouldn't ever have to go to hospital for, malnutrition, dehydration, those kind of things. And we also need to stop, once and for all, time and task-based approaches. If you're measuring people by the minute, you can't expect them to think about outcomes. And the budgets that I mentioned in silos are real problems, so we need to do more to pool the health and care budgets, offer block contracts to providers, which we've seen during COVID has really helped to maintain provider stability. It's given security of income, which then encourages investment in the workforce, in training, in innovation. And fair fees, and evidence-based approach to setting fees. Technology needs to be included as a core part of home care and what I call pre-care support for citizens. It's quite interesting to me that, you know, there are some local authorities, for example, that are blazing trails ahead in terms of thinking about technology, but the way that they go about commissioning and purchasing home care is just the same as it was 30 years ago. And until those two aspects are tied together and combined in a way that, you know, makes the whole package commissioned together, we're never going to get anywhere. And people receiving care and the providers need to have more responsibility, you know, delegated to them. They need to be in the driving seat. They need to decide the details. And in some areas, we're seeing really positive developments whereby GPs are now talking directly to home care workers, recognising that they're the ones that are seeing people face to face every day. We need to encourage greater collaboration. Others like nurses, physiotherapists, occupational therapists, pharmacists, all working together in primary care networks. That's how we're really going to get a difference. So just to sum up, we need to focus on outcomes. We need to agree what we need to measure, and everybody needs to measure the same thing so that we can get comparisons across integrated care systems. we need to invest in the workforce so that they can embrace these changes and innovations. And we need to incentivize and encourage innovation which does also require us to change the way that we think about home care and how we go about commissioning and purchasing it. And obviously we can't do the latter unless we have long-term reform. We're really grateful to hear that the government is thinking about this seriously, proposing to say something in the Queen's speech. We absolutely need to land this. And as others have said, the progress very much depends on building positive relationships. Much can be achieved within current resources and structures if there's a collective willingness to collaborate. And during COVID, we've really seen the opportunities there, and it's been very heartwarming and encouraging to see just how well local systems have pulled together. So that's where I'm going to finish, David, so thanks very much.
Thank you very much indeed, Jane, and a kind of tour de force, I think, of a number of issues about what can we do differently, but also sort of urging for best practice around commissioning, as well as having the integration of the technology with things that are about the overall commissioning of the service. So in that context, I wondered, Jane, what outcomes do you think we should be measuring? Because in a way, getting this right is partly about setting the right strategic objectives, isn't it? So I just wondered if you've got anything to say about that.
Well, I think there's an international consortium on health outcome measures, and NHS England has supported that, working with people across the globe. And I would be advocating that we try to agree on some common benchmarks, and a huge amount of work has already been done. So, for example, there are standard sets for different areas. So there's one for older persons, for example, which includes a whole range of different measures, things like falls, loneliness and isolation, ability to do activities of daily living, pain indicators, mood indicators, polypharmacy, so how many medicines are people taking, all of these different things. I think the real key is that we agree some standards and everybody uses the same ones, because then we can start comparing across systems.
Yeah, that sounds really interesting and very important way of thinking about this. The other thing is, you mentioned how people are integrating technology into what they're doing. How many home care providers do you think are really systematically integrating technology into the work that they do?
There are quite a number, mostly I would say in the private pay part of the market, where they're not constrained by the way things are commissioned, because the person receiving support is basically the commissioner. And we've seen some really excellent practice in that in some of those areas. I think many of the state-funded providers are quite hampered, as I've already said, because they're measured by the minute. The technologies are not really commissioned as part of the care. It might be something off on the side, and there often is no training available for the care staff, if it's there. So I think that it's very, very patchy. There's a few examples of outstanding practice, but I would say that the vast majority at the moment, even if they'd like to, aren't really able to engage, either because they can't see a way of getting a return on investment, or because the way that care is purchased just is a huge barrier.
Thank you, Jane. Yes, and I suppose one of the tricks here is to make sure that we highlight those areas where it is being done well and where people have managed to overcome the barriers, and in order to develop that great practice. So, Jane, thank you very much indeed for your talk this morning, and for sharing your thoughts about, is there a different way of doing things?